It is our distinct honor today to have Dr. Sinsky with us. It was sort of a lark that I contacted AMA to see if it was possible for her to come down here, and darned if she didn't, partly because of a family connection I hear, but anyway, we're really honored to have you here today. Dr. Sinsky is really one of a handful of the foremost experts in physician wellness, and whether you realize it or not, you should be grateful to her and some of her close colleagues for the work they've done these last few years. I suspect that at the core of her expertise is her 30-plus years practicing as an internist, which must inform her work. She's been on the cutting edge of research, innovation, and writing on the prevalence, drivers, and solutions of burnout and physician distress. And she's really, in her work, is a shining example of the way that AMA has reemerged in these last few years, from my perspective at least, to bring relevance to all of us in our work. And really, they should be congratulated for the work that Dr. Sinsky and those like her is doing. So anyway, Dr. Sinsky, thank you so much for being with us here today.
Great. Thanks so much, Dr. Sayers, and it's really my pleasure to be with you, and what an honor to follow some just truly terrific speakers. In fact, as I mentioned to Jeff, I sat up there and furiously made a few changes to my slides so that there would be even a few more connections between what we're saying, what we're talking about. So we'll be talking about creating a manageable cockpit for clinicians, fixing the workplace rather than the worker. Because it's not the worker that's broken, it's the system in which we are working. I think we have heroic physicians and nurses and others who every day are fighting against a system that keeps them from living up to their aspirations in entering the healing professions. And so I'd like to share some thoughts about how we might create more manageable cockpits for physicians and their teams. Our agenda will start with some introductory comments and level setting around burnout, and then we'll talk about some of the research, but we'll focus primarily on solutions. And then we'll end with some voices from physicians, and then hopefully some time for a conversation. I'd like to start with a couple of takeaways. The first is that care of the patient requires care of the care team. That the way we'll get to the triple aim of better care for individuals, better health for the population at lower cost, is by considering that fourth aim of health professional well-being. And that while burnout manifests in individuals, it originates in systems. And so I think we really have to focus the majority of our attention on reorienting our systems to our values, as opposed to reorienting our individuals to the system. So one of the things that I have noticed, and as Brian mentioned, much of this work emanates from 32 years in practice. My husband, who's in the back, and I were part of a group of about 150 physicians and APPs for 32 years. And we landed in an organization, multi-specialty organization, where all the physicians were owners of the practice. We also owned a health plan that covered about a third of our population, and we were physicians. So we wore three hats, and we were an ACO, if you will, well before ACOs were a thing. And over the course of our careers, we've noted this evolution to a very transactional conceptualization of healthcare, where healthcare is conceived of a series of episodes or transactions that could be delivered by anyone. Anybody will do. Any individual can round on a patient. Any individual can be on the other side of the telemedicine screen. It's all about tick boxes and metrics. And I think that with that, we have lost connection to the fact that at its core, our work is relational. And we are better diagnosticians. We are better healers. We are more healed ourselves, if you will, when we have deep connections with our patients and with each other. And so I think it's important to think about how do we rebuild all of the infrastructures within healthcare to be reoriented around supporting relationships. How do we take our physical structures, our billing structures, our technology, our staffing models, our scheduling models, and reorient them to support relationships? And in fact, I think when we do, that's the shortcut to getting to the quadruple aim. That if we, with some colleagues, I wrote a paper which I haven't included here, but on the radical reorientation of the US healthcare system around relationships. And we give very, very specific examples of ways that in technology and policy and payment and scheduling, you can reorient the system to prioritize relationships. And I'd like you to think about, how would care look different in my sphere of influence if we looked at all of our decisions through the lens of what does this do to relationships? Does it strengthen the opportunities for continuity? Does it strengthen the opportunities for stability within the team? And I think when we do that, again, that's the shortcut to the quadruple aim, and certainly is the shortcut to reducing burnout. So let's look quickly at the data around burnout. We've been tracking this with researchers from Mayo and Stanford since 2011, using the same methodology every 3 years. And so we've been measuring burnout, and in 2011, it was 45%, then it hit a peak at 54% in 2014. That was at a time when EHRs were being much more widely implemented. By 2017, things had decreased a little bit. And by 2020, the first year of the pandemic, we didn't know what we would find. Would we find that burnout had gone up or had gone down, given the impact of those first 9 months or so of the pandemic? And what we found was that burnout rates dropped to 38%. So those are the physician numbers in green. In blue is the general population. I'm not sure where that's coming from. I hope it's not too distracting to you all, but then in blue are the burnout rates among the general population, and even after you control for hours worked, educational level, age, gender, relationship status, burnout levels in physicians have always been quite a bit higher than the general population. So after 2020, and we saw that the burnout rates were quite a bit lower in the first year of the pandemic, by 2021, there was no longer the pots being pounded for physicians, and we were no longer the heroes, but there was a lot of politicization of medical care, and we wondered where things would be a year later. So we did a mid-cycle survey using the same methodology, and burnout rates had increased to 63% among physicians. And we know that this entire trend is not because there's a resiliency deficit among physicians. In fact, another study that we did demonstrated that physicians have a much higher level of resilience than the general population. So the answer to burnout is not to admonish physicians to just be more resilient. So one of the factors that I think has contributed to burnout has been our technology, and how our technology hasn't always been suited to meet the needs that we feel we need to meet patients' needs. And over the course of my 32 years of clinical practice, the first 16 years were in the paper world. Toward the end of that, we're just like, oh, if we had a computer to do this, life would be so much better. And then the second 16 years with the EHR, life did get better in some ways, but it got a lot worse in unexpected ways. And I've come to call this the great work transfer. That work that used to be done in our system by a ward secretary, a receptionist, a medical records clerk, a transcriptionist, a pharmacist, all of that work was gradually pushed to the physicians and APPs. And I think partly because of our culture, we took it on, our iron dot culture. We can take a little more. Yeah, I can put in those orders. Yeah, I can do this. Yeah, I can do that. But in the end, it comes then to the cost. And the cost is that we spend 2 hours on EHR and desk work for every 1 hour of direct face time with patients. A study we did a few years ago with medical students doing direct observation of physicians in 4 specialties, 4 different states, 7 different EHRs. And we found this 2 hours on the EHR to every 1 hour of direct face time. And I think we also have this cognitive overload. We're in this chronic state of giving our patients continuous partial attention. And yet I believe our undivided attention is what patients need and we need to be giving. In fact, our undivided attention is our superpower. And so, again, I think if we reorient the system to prioritize relationships and to prioritize our ability to give undivided attention, the quadruple aim will be closer to being achieved. So here's a study that I mentioned with direct observation. We found that physicians spent 50% of their workday on the EHR. And despite this, family physicians and general internists were taking 1 to 2 hours of work home every night, work that's been dubbed pajama time. All right. We're always going to get a little preview. That'll tell you where we're going next. And this is another study. This is from the University of Wisconsin, which is located right next door to Verona, Wisconsin, which is where Epic is from. And they were able to look at Epic's metadata for 142 family physicians over a 3-year period of time. And then they validated this with direct observation. And they too found that 50% of the workday was spent on the EHR. And I would say that 4 of the 6 hours on the EHR is work that does not require medical education to perform. So order entry, billing, coding, documentation, the physical act of sending refills, all of that can be done by an upskilled team. And this is their graph of how time was spent, again, using EHR event log data. And you can see, I want you to look at the orange line. That's on the weekends, and those are the hours of the day on the horizontal axis. And you can see there's a peak in physician time on the EHR on Saturday nights. So how much recovery are we getting if we're spending hours, particularly on the weekend, catching up? And I want to focus particularly on the dreaded inbox. And I believe that the cliche is that people don't leave their jobs, they leave their bosses. But I think for physicians aren't leaving their jobs or their bosses, they're leaving their inboxes. That the inbox has just become an unmanageable second career for physicians without the additional time. This is pre-pandemic, also using audit log data. And these family physicians were spending an hour and a half every day on the inbox. Post-pandemic, there's been a 57% increase in the amount of time that physicians spend on patient medical advice requests, that fraction of the inbox that requires the most time. This was looking at the entire US user base of Epic, and they were able to track the inbox volume. So even after telemedicine visits started to come down, even after the pandemic kind of settled down, the patient portal message volume has not. And we know that higher rates of inbox volume are associated with burnout. So if you have over 300 messages a week, you have 6-fold increased odds of burnout compared to those who have less than 150. The average primary care physician has over 100 inbox messages a day. Likewise, if you have a lot of pajama time, you have 13-fold increased risk of burnout. If you've got more than 3 hours a week, again, family physicians and general internists have 1 to 2 hours every night. But if you have over 3 hours a week, you're at 13-fold higher odds of burnout than if you have 30 minutes a week. EHR has been harder for women. And it's not because women are slower or even that women document more. It's that patients and staff make about 25% more requests of their female physicians than they make of their male physicians. So women spend more time every day, 41 minutes more in the EHR than their male colleagues, 3.5 hours more on the inbox in a month. And then I also added in there some of the evidence on childcare stress, that the pandemic has been more stressful for women in terms of childcare stress and odds of burnout. So why do we care about burnout? Well, we care about burnout because it affects our patients. We make twice as many mistakes if we're burned out. There's higher rates of mortality if nurses and physicians are burned out. Their patients in the ICU have higher rates of infection and higher rates of mortality. Patients are much less satisfied with our care. It affects physicians and other professionals, higher rates of divorce, higher rates of different diseases, and even death. And caring about burnout is a business strategy because burnout is really expensive to organizations. We have higher malpractice. We are twice as likely to leave an organization if we're burned out, and we have higher costs. And we did a study with a health economist from the Harvard Business School. Using published data, we were able to identify and then create algorithms which we built into this calculator that's available for free at the AMA, where you can put in the number of physicians in your organization, your rates of burnout, and we've pre-populated with a very conservative cost of replacing physicians of $500,000 per physician. Estimates are up to $1.4 million to replace a physician when you're talking about recruitment costs and lost productivity. So a group of 1,000 physicians is every year spending $13 million on burnout. They're just spending it downstream, replacing physicians who have left because of burnout. Investing a fraction of that upstream to reduce the drivers of burnout has a positive ROI. So we're going to turn to solutions, and I want to frame the solutions using the Stanford WellMD model. How many have seen this model before? I know that Claire has. A few of you have. Well, I want you to focus on the areas in red because those are the areas that are under a systems control. Organizational culture, things like the leadership, the amount of connectedness and meaning in work that we have. Practice efficiency, team structure, skill level, stability, EHR issues. And then the blue is personal resilience, although I like to reframe that as institutional support for individual self-care. How does the institution either help or hinder you from completely unplugging when you're on vacation? Is there inbox coverage when you're on vacation? Is your compensation model designed in a way that is a barrier to taking all of your vacation because you have to meet a certain productivity level to get into the bonus round and that sort of thing? So I think there's a lot that institutions can do for personal resilience as well. And I think here I'll mention a couple things that came to my mind with Dr. Hutchinson's talk, and I went back and refreshed my memory on this. It turns out that leaders really matter, and the behavior of leaders really matter. And so the leadership score of a physician's immediate supervisor predicts the rate of burnout 2 years later among those physicians that they lead. The leader's self-care, their sleep, for example, predicts the amount of burnout and sleep among the people that they lead. So the impact of leadership is really important. And the leadership score of one's immediate supervisor is responsible for about 50% of the variation in professional satisfaction and about 11% of the variation in burnout among physicians. So any of you who have leadership roles, it's just really important to recognize that your own personal self-care and your leadership style, your attentiveness to the career goals and other things for the people you lead has a big impact. Okay, so well, let's just go on to, we're going to start with practice efficiency. We'll skip that slide because this wants to keep moving. And it's my contention that most physicians in most specialties can save 3 to 5 hours a day by re-engineering the way the work is done and by more strategically sharing elements of care with an upskilled team member. And I've listed some of the things in the outpatient setting. By doing pre-visit lab, you can save 30 minutes a day. Do the labs ahead of time. You're not chasing after patients after they leave with those results as they come in. You're talking about them in context with the patient, face-to-face, and you review the whole situation once while you're with the patient. It's much safer that way as well. Taking a standardized approach to prescription management, 90 days plus 4 refills for chronic stable conditions, reduces all that churn of all those inbox messages for prescription renewal and the safety hazard of potentially renewing something because the pharmacist has required it by, or has requested it just by rote, but the patient isn't taking it. But now you've reordered it, and now they think they maybe should be, and probably it's not necessary. So there's a lot of safety issues as well as time saving with prescription management. But the one we will focus the most on is team documentation. But these apply to the outpatient setting, but the same underlying principles apply to the inpatient setting. And so when Tom and I worked as hospitalists as part of our work in our practice as internists, we rounded with a team of a nurse, a pharmacist, and a physician. And we were able then to share the care in real time as we were rounding. So the orders were put in before we left the room. The documentation was done before we left the room. The expertise of the nurse and the pharmacist was integrated into the care of the patient right at the bedside. So same ideas, just a different setting. So saving time for inpatient and outpatient physicians. So we have at the AMA a lot of resources that we've made available. The AMA has invested many, many millions of dollars over the last 8 to 10 years addressing physician well-being, physician and team well-being. One of the resources we've created is a Saving Time Playbook. You can go to the QR code and it'll take you right there. You don't need to be an AMA member. There's no username or password to access any of this. Our Saving Time Playbook has stop doing unnecessary work, incorporate the practice fundamentals, how to make the case to your leadership, and there's a lot of detail within all of that. And we have podcasts and webinars on many of our playbooks and on many of the component toolkits that are built into those playbooks, so you can listen or watch or read, whatever your style is. So we talked about saving time, and one of the strategies is to flip the clinic and do the labs ahead of the appointment. Here's data that shows that that decreases the number of phone calls and letters and other communication, saves $26 of overhead per visit by not doing all that rework. We also talk about going upstream. We started to talk about the 90 days plus 4 refills. We found that saves about 30 minutes of physician time per day and about 60 minutes of nursing time per day to go upstream and eliminate the requirement for doing that same work over and over again. We renew the prescriptions that are stable for 90 days, 4 refills. That gives you over a year's interval, 15-month interval. Now, you still see the patients as their conditions require throughout the year, but you haven't loaded your team and yourself with repeating unnecessary work. We have another playbook on taming the electronic health record, similar set of curricula. It pulls in lots of our Steps Forward toolkits that you can then go to dive deeper into the concepts that are shared. And one of the concepts that we share is team documentation. And team documentation means it's not only the physician who is empowered to enter things into the electronic health record, that our team can begin to do documentation during the rooming process. In more advanced models, a team member stays with the APP or the physician while the patient and the physician are interacting, and they continue real-time order entry and real-time visit note documentation to reduce the time costs. This was published by Dr. David Rubin at UCLA, and they found that with that kind of a model of team documentation, oops, I'm sorry, I thought we had the data on there. They were able to save 1.5 hours of physician time for every 4-hour clinic session. So they saved 3 hours of physician time every day just by having that assistant in the room present. Think of what you can do with 3 hours a day. If you spend 1 of those hours seeing 2 more patients a day, you've covered the cost of that individual, and then you have 2 more hours for improving the system and improving your own well-being. This is a similar model at the University of Colorado. They started it in their residency program. So their interns got a 1-to-1 ratio with an MA. By the second and third year, they got a 2-to-1 ratio, 2 MAs per doc. And the MAs stay in the room with the physician. Their faculty also got this, and they found that their burnout rates dropped in half in a year. And without being asked to increase their capacity, they increased the number of patients seen by 3.5 patients per day. Imagine what that increased capacity means in terms of your ability to see new patients and your ability to see provide same-day access and continuity to your existing patients. So let's then switch to organizational culture. This is one of my favorite New England Journal of Medicine articles. It was written by Dr. Melinda Ashton from Hawaii Pacific Health, Getting Rid of Stupid Stuff. So we then asked Dr. Ashton to help us write a toolkit. So we have a steps forward toolkit called Getting Rid of Stupid Stuff. It is a step-by-step guide for how you can initiate that in your environment, wherever you are, whether you're in a small or a large system. And so we welcome you to take a look at that. And she has also done podcasts for us and webinars. I'd like to focus on the inbox again. This is Dr. Jane Fogg. She had been a leader at Atrius Health in Boston. She's joining our team in the next several weeks. And she led a 5-year initiative at Atrius to reduce the inbox volume. And what they were able to do was decrease the number of CC charts, all those for your interest. Here's the note from the dermatologist and from the ophthalmologist, et cetera, by 40%. They were able to reduce the ADTs, admission, discharge, transfer notifications, by 100%. Prescription renewal requests by over half. And she and I wrote together a New England Journal of Medicine Catalyst article going over all of their data as well as how they did it. And then we also have a inbox reduction toolkit that we created, and she builds on her experience and gives a step-by-step approach on how you can address reducing the inbox in your organization. Well, if you're not interested in reading the whole toolbox, we also have a checklist. And this checklist is something that she and I put together, and then I sent it around to about 11 CMIOs around the country for their input. And so we have a checklist of things that you can consider doing at your organization to go upstream and reduce the volume of inbox work coming into the inbox, and then ways you can share the inbox with team members. On the same note, we have a de-implementation checklist. There are lots of policies and procedures that have been implemented in organizations that were well intended at the time that they were initiated, but they may never have lived up to their intention, or they may have outlived their usefulness. And it's time to cull the system of those outdated or harmful policies. And so we have a de-implementation checklist. And again, I've put the QR codes there. We sent the checklist to the Joint Commission, who's been a wonderful partner with us in a lot of this work. And so they reviewed it. We made a few adjustments based on their feedback. So we know that this is consistent with Joint Commission standards and therefore also consistent with CMS requirements. So I've underlined there decreased password-related burdens. And last spring, I got a call from the chief wellness officer at Kaiser in Southern California, and she said, I'm so excited to tell you we're about to turn off our requirement for password revalidation. In their system, even though you'd already signed in with username and password, and you were in a patient's record, if you were modifying an acetaminophen dose, if you were sending a prescription for lisinopril, whatever you were doing, if we're talking non-controlled substances, you had to re-enter your username and password. And that is a practice in many systems, but it's not required. There's no federal, or to my knowledge, no federal requirement and no state requirement for that. It made sense at a time to some people, but it's not necessary currently. And they estimated that they were able to reduce the decrease the number of password entrances by 1.5 billion every week for Kaiser in Southern California. I mean, that's a lot of unnecessary keystrokes, and there's so much sludge and waste in the system. And so there's opportunities for leaders and for those who aren't not leaders to look at what are those things that we can elevate to say, we don't need to do that anymore. So again, the de-implementation checklist can give you some ideas. One of the things I'm most happy about is our initiative debunking regulatory myths. Because I think a lot of the sludge and a lot of the waste of time starts with a well-intended federal policy. It gets exacerbated by overinterpretation at the local level, and then it's implemented through our technology. And yet, if we go back to the source, we often find that the federal policy was misunderstood in that local overinterpretation. And so we have now about 12 different myths that we have debunked. And you can go, again, with that QR code or just Googling debunking regulatory myths. And we will take you to, there'll be a PDF that you can share with your leaders, and we'll take you to the place in the Federal Register or in the Joint Commission standards that debunks the particular myth that we're speaking about. So I want to conclude with a couple of the first takeaways, and then we're going to bring in the voice of the patient. So those takeaways, that while burnout manifests in individuals, it originates in systems. And I believe we have an incredible opportunity to redesign the systems, to make small tweaks here and there within the system, to remove those pebbles in the shoe, to remove the boulders on their backs for ourselves and our fellow colleagues, so that while burnout manifests in individuals, it originates in systems. And we talked about the quadruple aim, that while the way we'll get to the triple aim of better care for individuals, better health for the population at lower costs, is by considering that fourth aim of health professional well-being. I'm trying to think of questions doctors ask. How have your blood sugars been? Always that question. The question I would rather hear, or would like to hear in addition to that, is not about the medical stuff. It's like they could simply ask, how was your trip here? I think that's all I crave, you know, not everything revolving around diabetes. It would seem really easy for the doctor to jot any simple personal anecdote in my chart and ask about it. It really connects me with them. And I'm much more able to receive advice from people I feel are thinking of me as a person rather than just the next patient. And this comes from a book written by an ID physician at the University of Iowa called Patient Listening, A Doctor's Guide. And I love the title for its double meaning, Patient Listening, A Doctor's Guide. If I had one metric that I would assess a health system by, I think it would be how much undivided attention are your clinicians able to give to their patients? And I think if we could measure that metric, which we can with a proxy measure using EHR event log data, and we've published a paper with the formula for that. But imagine a world where health systems, the whole system and then individual units within, optimized around maximizing the amount of undivided attention clinicians gave their patients. I think we'd get to the endpoint that we strive for. When I get bored with my work, I realize I'm not paying attention to my patients or their stories. And certainly Dr. Gomez gave us wonderful snippets of stories from patients and how meaningful those are. So I'm going to show you a few photos that patients shared with me. One of my favorite approaches to patient care was to ask patients, bring me a picture of at your next visit. bring me a picture of whatever we were talking about. And we had a bulletin board, and we had a lot of those pictures up on the bulletin board. And this was a patient who she and her husband enjoyed doing Civil War reenactments. And seeing that aspect of her, so she wasn't just the person in the exam room, but having that fuller view of her was meaningful to me. This is a PhD in physics who had MS, and he designed a lot of the adaptive equipment. This was probably 20 years ago. And knowing him and knowing his story was really important. He was the first person, this, like I said, was about 20 years ago. We didn't have patient portals, had none of that. But I asked the nurses every day in the hospital to print the results of all of his lab and all of his test results and give them to him, because he was a really active participant in his care. I have to keep reminding doctors, as well as myself, not to let illness define me. It's in attendance, but it is not all that I am. With permission, this is a photo. Whenever I would get despondent about the frictions within healthcare and within our practice, my husband would remind me of this patient, whom I cared for many years. And I sat on his bed the night before he died. We both knew that he was dying. Vascular disease had eaten up his lower extremities. It had taken away his intestines. But every day when I left the hospital, his room, he would say, "Thank you, Dr. Sinsky." And one time in an office visit, he shared with me an end-of-life experience that he had had at the conclusion of a surgical episode where he almost did not survive. And those moments of connection with patients are so meaningful. And yet I believe that we've crowded out the opportunity for those by requiring that our doctors do all the order entry, by requiring that the doctor be the one who's the first responder to the inbox. And really, that's a medical school education is a terrible thing to waste. And having that as a requirement wastes that education and doesn't allow for those moments with patients, doesn't allow for that continuity, doesn't allow for that access. This is Dr. Marie Brown. She's one of my team at the AMA. And early on in our friendship, she said, "I go to work every day and visit with old friends." So we'll end with the quadruple aim: care, better than we've ever seen; health, better than we've ever known; cost, we can all afford; delivered by professionals who find joy in their work as they commit to serve others. And with that, I'd like to thank you very much for this whole morning and for your attention just now. Thank you.